Welcome to the third module of this session, Systematic Causes of Error. The goal of this module is for learners to understand how system-related factors contribute to diagnostic errors. The learning objectives are to list systematic-related causes of diagnostic errors, differentiate between perceptual and interpretive errors, and list examples of perceptual errors. Errors are commonly caused by faulty systems, processes, and conditions that lead people to make mistakes or fail to prevent them. These types of errors are distinct from cognitive errors. System-related causes of diagnostic error include visual and mental fatigue, technical errors, inefficient processes, poor communication, lack of available patient information, poor teamwork, increased workload and understaffing, policies and procedures, and workplace distractions. These factors likely underlie many of the diagnostic errors we encounter in radiology. Perceptual errors occur when an abnormality is present on a diagnostic image but not seen by the interpreting radiologist. Perceptual errors are often the result of system-related factors, but can also occur due to cognitive biases. Interpretive errors occur when an abnormality is identified on an image, but its meaning or importance is incorrectly interpreted. Interpretive errors are often the result of cognitive biases. In this module, we will focus on perceptual errors that are caused by systematic factors. The first case is an intraoperative plain film that was obtained in a patient undergoing liver transplant that has a missing sponge. The radiologist identifies the enteric tube and the embolization coils overlying the left upper quadrant. This radiologist then concludes that there's no evidence of retained sponge. The patient has hepatic artery thrombosis and goes back to the operating room the next day, and that's when they find the sponge. There are a few reasons why this is missed. One reason is that the study is technically limited. It's a poor quality study that's underexposed. Another reason is that the finding is on the edge of the film. This is one of the most common causes of perceptual error and is likely driven by the systematic causes we talked about before. The next case is a patient who has status post-radical nephrectomy for renal cell carcinoma. The radiologist reviewing the CT exam looks at the lung bases on the 2-minute delayed series and determines that there is no evidence of metastatic disease. However, if we look at the top slice of the non-contrast series, we see that there is a new lung metastasis that the radiologist missed. The systematic factor causing this miss was that these two series started at different places. The next case is a patient with metastatic renal cell carcinoma status post-nephrectomy. The interpreting radiologist missed a subtle osseous metastasis in the left ischial tuberosity. This is a common cause of perceptual error, edge of the film miss. This finding was on the bottom few slices of the CT exam. The next case is a patient who gets CT imaging for follow-up of an abdominal aortic aneurysm. The interpreting radiologist missed a spiculated lung nodule in the right lung base representing cancer. This finding was missed by the same radiologist on 2 subsequent studies 3 months apart. Let's think about the contributing factors for this miss. Could it be that the lesion was located on the top slice? Is it that there were more than 2,000 images in this exam? Is it because the study was performed as a vascular study evaluating the aorta after AAA repair and not for lung cancer screening? Or is it because of inadequate knowledge of the radiologist? Well, it turns out that the top 3 contributing factors are very common causes of perceptual errors. However, inadequate knowledge is rarely a cause of error. This is a CT exam performed in an ER patient with right upper quadrant pain. The interpreting radiologist missed a left common femoral deep vein thrombosis. There were multiple contributing factors for this miss. One is that the radiologist was covering multiple hospitals after his colleague had called out sick. Another is that the ER physician called the radiologist for a prelim report, which interrupted his search pattern. Another reason is the radiologist was using a structured template that had pre-filled fields, and he didn't realize that he didn't look at the vascular structures. As is the case with many errors, there are multiple contributing factors. The next case is an MRI performed in a patient with sarcoma and liver metastases. The radiologist determines that there are multiple new liver lesions concerning for metastases. However, he misses a new large sigmoid metastasis from sarcoma. The reason this was missed is because it is only visible on the Scout T2 image, another example of an edge of the film miss. The next case is a patient with renal cell carcinoma status post-nephrectomy. The interpreting radiologist missed a new spinal metastasis, which you can see on the post-contrast images above and the diffusion-weighted images below. When we look at the CT from 4 months previous, we see that that radiologist also missed the spinal metastasis. Now, when you have perceptual errors like this, it is likely that systematic factors contributed, things like workload, staffing, fatigue, and interruptions. This next case is a patient with appendiceal cancer follow-up after cytoreductive surgery. The radiologist is an experienced abdominal imager who knows where appendiceal carcinoma likes to hide. However, he misses this implant in the left lobe that's occluding the left portal vein. There are likely systematic factors contributing to this perceptual error. This is a CT exam with an indication of left lobe liver mass, evaluate for metastatic disease. The patient's primary tumor is anaplastic hemangioparasitoma. The interpreting radiologist reviews this exam and determines that there is no evidence of recurrent or metastatic disease. However, if we use liver windows, we see that there is a subtle metastasis in the peripheral aspect of the liver. This is a common cause of missed liver lesions, not using liver windows, and background steatosis, which makes liver lesions more difficult to identify. This next case was an X-ray of the abdomen with an indication of feeding tube. The interpreting radiologist correctly identified a feeding tube terminating in the peripyloric region and then moved on to the next case. However, he missed the feeding tube in the right lower lobe. There are multiple reasons for this diagnostic error. One is that this is a technically limited study with motion, and that makes that second feeding tube very difficult to identify. Another contributing factor is likely satisfaction of search. And a third potential contributing factor is a form of framing bias, where the referring physician did not indicate that there was more than one feeding tube. This is a CT exam performed in a patient with chronic abdominal pain. The interpreting radiologist sees high-density material throughout the colon and attributes this to barium. However, when looking at the scout view, we see that there is a retained surgical sponge next to the descending colon. It is likely that when you come across errors like this, that there are systematic factors contributing to this perceptual error, such as workload, fatigue, and interruptions. To summarize, errors are commonly caused by faulty systems, processes, and conditions that lead people to make mistakes or fail to prevent them. Systematic causes of error are distinct from cognitive errors. Perceptual errors occur when an abnormality is present on a diagnostic image but not seen by the interpreting radiologist. Perceptual errors are often the result of system-related factors, but can also occur due to cognitive biases. Interpretive errors occur when an abnormality is identified on an image, but its meaning or importance is incorrectly interpreted. Interpretive errors are often the result of cognitive biases. In the next module, we will discuss how to recognize when you are about to make a cognitive error.